Hello, Real Clinicians. This is Ali Nasseh, and today I have the pleasure of being joined by Dr. Will Giannobile. Dr. Giannobile is the chairman of the Department of Periodontology at the University of Michigan, and also the editor-in-chief of the Journal of Dental Research, which is the monthly publication by the International and American Association of Dental Research. Dr. Giannobile has a long list of accolades and a bio that will rival anyone's and will likely take up the whole session if we were to discuss it all. Incidentally, he was also my classmate about 25 years ago at Harvard, where he was studying perio while I was studying endo. Dr. Giannobile, thank you so much for joining me.
Oh, my pleasure. It's great to be with you, Ali, and have a chance to talk with you today.
Oh, absolutely. My pleasure. Dr. Giannobile, I might call you Will. I wanted to speak to you today regarding a new Swedish article that was published in this month's JDR on the prevalence of periimplantitis. Now, you wrote a very impactful editorial in response to this article, summing up several recently published articles for a new call to action. And this is why I wanted to talk to you. However, before we get started, if you wouldn't mind, please can you give us a little bit of a definition of periimplantitis for our viewers? Can you just tell us what is periimplantitis?
Sure. It's a great question because there's been a lot of controversy within the literature in terms of defining what periimplantitis is. But essentially, periimplantitis is an inflammation and an infection around a dental implant that has led to both mucosal and bone destruction around the dental implant itself. So basically, it's a condition where there is now bone loss, soft tissue downgrowth around the dental implant fixture. Whereas we also hear about the definition of perimucositis, where that's the inflammation primarily just from a soft tissue aspect. So it's really the corollary to gingivitis is perimucositis and periodontitis and periimplantitis.
So pretty much just like periodontal disease, it is always triggered. It's an inflammatory response to pretty much a bacterial component, correct? I mean, it's not a foreign body thing. It's primarily directed by bacterial components, correct?
Correct. Yeah. And, it's as we've looked at the perimucositis versus periimplantitis, periimplantitis is driven primarily by bacterial plaque, leading to inflammation around the implant. And there has been some discussion as well looking at, is it a foreign body reaction? But our current evidence is suggestive that it's primarily due to the bacterial plaque around the implant. In some cases, it can be driven by the presence of cement that might serve as an initiating factor, especially in some of these implants that have had, very deep restorations around them that could then serve as a trigger to form bacterial plaque on the implant itself.
According to this article that was published in the JDR, in a random group of Swedish population, it was in Gothenburg, I think, there were severe periimplantitis in about 15% of them. And then there was about mild periimplantitis in a total of about 45% of these population. Now, that's nearly half the patients that were treated with implants, correct?
Right.
So has the incidence of periimplantitis gone up over the years, or has it always been this high, but it was probably underreported due to whatever ways we had decided to measure success? And how does this correlate with some of the original Brandemark studies?
Yeah, this paper that came out recently in the JDR by Dirks and coworkers has been a very illuminating study because it is focused on bone loss around implants. And so as we look at the literature, there had been a focus initially on survival, and basically what survival of a dental implant is, the presence of the implant over time versus success of implants that might also relate to a biological complication or a restorative complication. And so this is then basically leading to a variety of different problems around the implant, even though it still may be in place. So much of that initial literature had focused on the survival, and now what we're seeing in contemporary implant dentistry is the focus on, okay, what is the longevity of the implants in terms of being able to create a nice soft tissue seal, maintainability of the implant fixture, and creating very stable bone levels, and having good restorative success without breakage of prostheses. And so, to your question, I think that there was likely some underreporting. Um, but also there has been, over time, there's been such a growth and an explosion in implant dentistry that now we have more and more individuals involved in the placement and restoration of implants. And certainly we have varying degrees of training in terms of those individuals that have gone through, full-blown programs, oral maxillofacial surgery, periodontology, implant dentistry, focused on implant dentistry, whereas there are some other types of individuals who've had more minimal training on both the surgical and restorative aspects. And so, some of the case selection, I believe, over time has shifted. Right? If we look at the original Brandemark studies, these were in the fully edentulous patients. And then over time, we're seeing more and more partially edentulous individuals, the single tooth implants being placed, and a variety of different patients with different risk profiles, i.e., those who've had past periodontitis. The Dirk study, what's interesting about this study, they looked at almost 5,000 patients from a Swedish national registry over a period of 9 years. And then they selected this group of just over 500 patients. And, they indeed found some differences in training, some differences in the restorative aspects as well, that being a very important component, as we know within clinical dentistry, that collaboration between the surgeon and the restorative dentist to make a cleansable prosthesis that's functional for the patient.
Yeah, absolutely. I mean, there's a number of factors. And in terms of these factors that cause periimplantitis, I mean, you mentioned certainly success and failure of implants and having a different definition for it. It's interesting because we went through the same thing with endodontics. I mean, the survival of endodontically treated cases is very high based on the Salabrabi studies. We're talking about 97%, but then some of the definitions in the past have been different in terms of success and full healing. So I also do agree that, obviously implant fixture stability alone can't be a measure of success. Ultimately, the patient, just same way for endo, they don't come in to save roots, they come in to have functioning aesthetic teeth. But for periimplantitis itself, what are some of the factors do you think? Do you think which one is more important, implant design, the surface treatment, or sometimes even the patient's own oral hygiene and home care? Because that's been something that hasn't been emphasized enough. I recall speaking to people that were saying, well, the good thing with implants is you don't even need to brush, you don't need to do anything. And it just seemed counterintuitive, understanding the role of bacteria usually in anything that has a connection with any other surface.
Right. I mean, Ali, you're bringing up a good point in terms of, there are a multitude of factors that are critical to the success of the implants. Certainly, oral hygiene, the patient's, dentition in terms of how well they're able to maintain everything is critically important. Many of these cases with the patients who are receiving implants, and they have that within their own mind's eye that has cured their problem in terms of having this tooth replacement. But I do think it's, the case selection, looking at those types of individuals that can maintain well. But we also know that the same risk factors that we have for the loss of teeth, in terms of, certain genetic factors, smoking, diabetes, other types of issues, occlusion that might result in fracture or periodontal disease. Those types of same risk factors affect, patients who have implants. And so, from that case selection, it's very important. And then part and parcel to that is the restorative aspects and looking at developing that functional occlusion, and in those patients also creating restorative margins that are really at that bone, soft tissue, bone, hard, the bone restorative margin interface is very important. Because one of the things that we have seen, over the years, Ali, is that, many of these cases that were selected, again, patients who were fully edentulous and looking at developing certain hybrid prostheses versus the single multi-tooth cases, and many of them now in the aesthetics zone where some of the implants are actually being placed, subcrustal, and then it creates challenges for the restorative dentist in really getting a restorative margin that's both aesthetic and then tissue compatible. And so when we look at the advent of cemented retained fixtures or restorative margins versus screw retained, there are a variety of other issues associated with that. But I think you've touched on key ones in terms of oral hygiene risk factors, and then the implant design piece itself. The Dirk study also saw some differences in terms of the implant surface, and that also is likely playing a role. But it's really a combination of factors, and I think this study really serves as one of the building blocks to further look at these other risk factors. Yeah.
Yeah, because it does seem very plausible that microsurface treatments of implants, once it gets exposed, and then it becomes basically a breeding ground for bacteria that would maintain bacterial infection. It's just common sense. We have the same issue with teeth, with tartar and calculus. Will, as far as the consumer is concerned, because just to take a big picture view of some of the definitions that we have and so on in terms of success, what is a conservative average for a lifespan of an implant that's placed in the premolar area of the maxilla, for example, with average bone quality and bone quantity that could be considered a healthy alternative to their tooth, so there's no chronic infection or something like that going on? What kind of a rate should we give a patient who's asking us, how long can I keep this, and what kind of a success should I expect from it?
Yeah, it's a tough one. As dentists, we want everything to last a lifetime, and certainly that's the challenge. And so looking at, keeping a functional dentition for a lifetime and doing what we can to keep the natural dentition. But, based on the evidence that we have, implants in a very healthy site, a patient that hasn't had a history of periodontal disease, has a good functional occlusion, we're seeing that the longevity for these implants is quite good, 10, 15 plus years. And what we're starting to see with the data in terms of survival versus success is that it's variable. And certainly we have teeth that have received periodontal treatment, endodontic treatment, that we can either do some sort of regenerative therapy and maintain these teeth at a very long lifespan as well. So it's hard to just give a hard and fast rule in terms of how long these implants will last. But certainly, as a part of this discussion, I have to say, implants have been one of the greatest innovations to dentistry,
no question,
and certainly are a critical component to reconstructing patients. But certainly one tool within our toolbox, and we'll never be able to replace the natural tooth.
No, of course, and that's part of your editorial that I'm trying to that we're going to get to. But so, do you think that the increase in the short implant training programs is potentially part of the reason? Because it seems like we have moved from a time during which we used to think of implants as an alternative to really, broken down teeth that really couldn't be saved, that were fractured and that were lost, to a change in philosophy almost. I recall this back in the 90s, where there was such an implant, euphoria. It was, that we kind of were thinking that, I even heard people, big names on the circuit say that implants are better than natural teeth, and even good teeth should be removed and replaced with implants. Do you think that in combination with this understanding led to a belief that so many people are getting trained, these short training for implant therapy, and that could possibly be, maybe the technique is in the case selection, the technique is kind of not quite merging into that perfect corner for the best outcomes for the patients?
Yeah, I think you're absolutely right. I think that, this rush in many cases to take teeth out prematurely that could be maintained. And some of the cases are just very challenging. We have cases where there's large dehiscences, localized bone resorption. Patients have, in some cases, untreated periodontal disease or other oral infections. And in some of these selected cases, they're receiving implants in the face of other, challenges within the entire case itself. And so I think just like with outcomes that we're seeing in medicine, the level of training, certainly from the patient point of view, you want to go to a practitioner that has the highest level of training possible for your specific condition. And so some cases are not really that slam dunk where it's a single tooth extraction, implant placement. These cases tend to do better. Again, if we look at the Swedish study, those patients who had a past history of periodontitis or other types of biological complications, multiple implants, those are the patients who tended to have more significant problems. And so these total reconstructions, oftentimes where cases had large numbers of compromised teeth that were replaced with implants. And in some cases, the practitioner's not really so well equipped to handle that complex case. So really this conversation and collaboration between, the restorative and surgical sides, degree of training, as you're pointing out, is very important.
Yeah, I think, as somebody who doesn't place implants, myself, and really having an outside perspective of the big picture of what is going on. I remember that the early studies by Brandemark were highly controlled, and then they had excellent patient selection and really good protocol. But I think as a result of what I just mentioned, is this exuberance, at times you may want to call it irrational exuberance over the success of implant therapy, it just became a panacea. And then we may have actually gone a little too far in terms of pushing the envelope in patient selection. And as a result, maybe this is a consequence of poor choices in terms of, applying this as a panacea to every case rather than treatment planning an individual patient.
Yeah.
I don't know if you feel the same way or not.
Yeah, I think you've stated it very well. I mean, I think what this is going to do is, as we've seen this, this mounting evidence regarding periimplantitis, perimucositis, that now the case selection, the maintenance, the collaborative treatment, this becomes more and more important. And that, there's so much from the diagnostic point of view, the risk assessment of the patient, that we have to now underline and focus on before we embark on, doing these large reconstruction types of cases.
So, Will, since we established that there is possibly an increase for various reasons in periimplantitis, you had a wonderful impact editorial in the journal can you just share what were your conclusions from this in terms of what would be best practices for us moving forward in terms of treatment planning and case selection?
Yeah, so the overall tone of our editorial, and really I would encourage your listeners to take a look at this particular issue of the JDR, because what we had done was we wrote this editorial to just look at creating a balance as we examine the reconstruction of our patients and the reconstruction of the dentition. Again, implant dentistry has been, a wonderful advance. However, this is something for us to kind of take a step back and look at the types of cases and the patients that we're recommending implants. And so without having this rush to extraction and looking at, conservative methods in many cases that are probably more appropriate for many of the larger cases, saving teeth due to endodontic therapy, periodontal therapy, occlusal therapy, doing these types of prostheses. And coupled with our editorial, we had one by Dennis Tarnow, who gave a very nice critique on the Swedish study. And, you had the question about, how long could you expect an implant to last? One of his corollaries that he mentioned in his piece was, as we look at, orthopedic surgeons with a total hip prosthesis, we use the term revision in terms of reconstructing these patients. What one of the bottom lines of the editorials was that, we shouldn't sell the implants to our patients to say that they're going to be a permanent solution. Okay, what we're finding is that just like the treatments that we provide to teeth and the total patient, The treatments that we're providing in terms of reconstructive therapy with implants it's an excellent treatment, but it's not necessarily a treatment for a lifetime. And we're looking at, how can we better maintain the implants? And then there's within this issue a couple of articles that look at reconstructive therapies, either antimicrobial therapy or types of regenerative therapies around implants. And what we find is, summarized in our editorial, but also the Tarnow paper and another paper from the Gothenburg group, is that to treat an implant that has now incurred disease is much more challenging than treating a tooth. The local delivery of antibiotics, resective therapy, regenerative therapy, all of these types of treatments, they do not work as well around an implant versus a tooth. That is very clear. And we have a research group at our university that done a systematic review cataloging all of these regenerative therapies, and they're still not that predictable, not as predictable as regenerative therapies around teeth. And so it becomes a real challenge to treat an infected implant or one that has already lost a significant amount of bone. And so what is being done in many of these cases in terms of that revision that Tarnow was talking about is many of these cases we have to simply remove the implant, remove that that situation that's just not manageable, and then start over, maybe doing some localized ridge augmentation or rethinking about maybe utilizing another type of approach for some of these high-risk patients.
It's actually interesting because Dr. Tarnow was one of the advocates of saying back in the 90s that, basically saving teeth through periodontal care and endodontic therapy is going to be obsolete in no time, and that everyone's going to be getting implants as the best permanent treatment option. So it's good to see that, people are coming to a good equilibrium and finding probably a good balance here between trying to preserve teeth. And with that, let's hope that clinicians consider treatment options as they relate to specific considerations in a given patient, while keeping the broader philosophical issue of respecting the natural biological tissues in maintaining the dentition, because clearly, it's important to really consider our natural biological tissues at probably at a little bit of a higher level than just merely numbers in terms of success and failure. Well, Dr. Giannobile, thank you so much for joining me. I really appreciate your time. I know you're a very busy man, and I do appreciate that you spent some time with me this afternoon.
Okay, my pleasure. Thanks so much.
Absolutely. Keep up the great work. Dr. Will Giannobile, the Chief Editor at the JDR and Chair of the Department of Periodontics at the University of Michigan. For Reworld Endo, I'm Ali Nasseh, and I hope you found this information helpful.